All right, so I'd like to thank the organizing committee for this opportunity to speak to you today. Thank you to Fabrice, and thank you to Donald for laying such a wonderful stage and setting up the stage for the clinical data for these agents that are currently in development. These are my disclosures. So let me start by actually walking you through the key milestones in the treatment of ER-positive metastatic breast cancer. It was nearly 100 years ago that Sir George Beatson showed us the benefits of oophorectomy and how effective it was in ER-positive disease, a finding that has led to the use of endocrine therapy. It was in the 1950s that Elwood Jensen described an entity that we call the estrogen receptor today. It was in the late 1970s that we had approval for the very first endocrine agent, a serum estrogen receptor modulator, tamoxifen. We then had aromatase inhibitors get approved for postmenopausal women in the 1990s. And then it was not until 2010 that we learned the right dosing schedule for the only approved serum estrogen receptor downregulator, fulvestrant. And since then, in the last decade, we've been following the current trend of utilizing endocrine agents as backbones alongside novel targeted therapies, initially with the approval of everolimus, mTORC inhibitor in 2012. And between 2015 and 2019, we have the CDK4/6 inhibitors that got approved. Most recently, we have approval for alpelisib, an alpha-specific PI3K inhibitor. So let's start with reviewing how does hormone receptor signaling really work. So the estrogen receptor has the AF1 function domain, so it's an activating function 1 domain, a ligand binding on an activating function 2 domain, and a DNA binding domain. And the receptor is complexed with HSP90, which maintains the receptor in an off state. When estradiol binds to the ligand binding domain, it triggers the release from HSP90, which then causes receptor dimerization and DNA engagement, then causing coordinated recruitment of cofactors and transcriptional machinery, which drives the gene expression changes. And there are 3 approved strategies to target ER that are currently available to our patients in clinic, including serum estrogen receptor modulators, or tamoxifen, that compete with estradiol to bind with the estrogen receptor. They have agonistic or antagonistic capabilities in a tissue-specific fashion, and they lead to inhibition of the ER transcription. We have aromatase inhibitors that prevent the conversion or inhibit the conversion from androgens to estrogens. And then we have serum estrogen receptor downregulators of fulvestrant, which not only inhibits ER transcription, but also degrades or downregulates the ER receptor itself. But while these agents are very effective and work for our patients, they do have their limitations, which are not limited just to their toxicity profile. For example, under the selective pressure of aromatase inhibitors, we do see acquisition of ESR1 mutations in the metastatic setting, and this leads to ligand-independent activation of ER transcription activity. Now, tamoxifen can also be a partial agonist, which can manifest as weaker ER suppression. And while fulvestrant is active after progression on prior endocrine therapy, including in some ESR1 mutant patients, its efficacy is limited because of its dose dependency, and it has some poor PK profile, lack of bioavailability, and recently data has suggested that single agent fulvestrant can cause a median progression-free survival of just 2 months post CDK4/6 inhibitor therapy. And additionally, its activity can be limited in certain ESR1 mutations, especially Y537S, which is one of the 2 most common ESR1 mutations that we see. Lastly, there is non-adherence that we see, which is a big issue in the early stage setting due to toxicity-related reasons. And in fact, a population-based study by Don Hirschman and colleagues showed that only 50% of the patients were adherent to the 5-year of endocrine therapy in the early stage. So how can we do better? How can we circumvent these issues of toxicity and the therapeutic liabilities of these currently approved endocrine agents? This has led to the premise of developing newer endocrine agents, such as novel oral SERDs, next-generation serum estrogen receptor modulators, SERM-SERD hybrids. We now also have complete estrogen receptor antagonist, or CERAN. We have SERCA, which is serum estrogen receptor covalent antagonist, and PROTACs, which are proteolysis targeting chimera. But the goal here of developing all of these agents really is that we want to downregulate ER with an agent that has the most optimal therapeutic index and superior efficacy, so that we can further improve outcomes and overcome the issues we face in clinic. Let's see. There you go. So let's start with oral SERDs. I think the key advantages of oral SERDs are, one, that they are an oral formulation, and that they have high potency when compared to fulvestrant in preclinical models. And activity for these agents was also seen preclinically in ESR1 mutant cell lines and PDX models, including with Y537S, which was resistant to fulvestrant. And talking about ESR1 mutations, they can be rare in the first-line metastatic setting, but the prevalence can be as high as 40% as detected in circulating tumor DNA in endocrine refractory setting. And this is a table that summarizes 10 active oral SERDs that are currently in clinical development, and I've highlighted the top 5 on this table that are already in phase 3 trials. Now, shown here are the swimmer's plots for select SERD in phase 1 trials. Now, these are trials where patients were treated heterogeneously with prior therapies, but what I'd like to draw your attention is to the dotted lines that you see here across these trials, which is the 6-month time point. And despite these prior therapies, which are heterogeneous, and despite prior endocrine therapy and chemotherapy, you see that there is a subpopulation of these patients that stay on therapy beyond the 6-month time point, which kind of tells you that if they could work in a refractory setting, perhaps the activity could be more robust even in a naive setting. And to provide further granularity for efficacy from these phase 1 trials, this is a table summarizing that data. Drawing your attention to prior CDK4/6 inhibitor therapy across these trials, about 50 to 60% had had prior CDK4/6 inhibitor therapy. About 60% had prior fulvestrant therapy. Again, this varied from trial to trial. And as in everything, the response rate in ER-positive breast cancer is rather low, but the clinical benefit rate, as shown here, is about 35 to 50% across these trials for these drugs. This table here summarizes oral SERD plus, or it's grouping oral SERDs with CDK4/6 inhibitors from phase 1 trials by pretreatment, really. So the top 2 here highlighted are the Novartis oral SERD with ribociclib and the AstraZeneca SERD with palbociclib, where patients had had 35 or 70% prior CDK4/6 inhibitor respectively, or about 60% prior fulvestrant-based therapy. And in those patients, the clinical benefit rate was about 35 to 50%. In the middle, you have the G1 Therapeutics compound with palbociclib, and with 15% of the patients with prior fulvestrant, the clinical benefit rate here was 60%. And for the last 2 agents here from Sanofi and Genentech, along with palbociclib, which were predominantly CDK4/6 and fulvestrant naive, you see that the clinical benefit rate here is about 75 to 80%. So here are a few things that we would want to learn from this. 1, that these drugs are active. 2, that these drugs can be combined with CDK4/6, and while they can have activity even post CDK4/6, they would be a good partner with CDK4/6 in the first-line setting. And this is what we actually see now that is happening in clinic. In phase 3 trials, these drugs are being evaluated in combination with CDK4/6 against our current standard of care, AI plus CDK4/6. They're also being evaluated post-CDK4/6 inhibitor therapy in comparison to standard of care physician choice endocrine therapy, and also with many other targeted therapeutic options that are all summarized on this slide. They're rapidly also being evaluated in early stage setting. And in fact, early data from the window of opportunity portion of a neoadjuvant trial, the Cooperative Trial, presented by Sarah Hurwitz at ESMO, suggested that there was a greater Ki-67 reduction at 2 weeks with oral SERD compared to anastrozole, and a higher complete cell cycle arrest was also seen in that study. And adjuvant phase 3 trials with this compound and others are either planned or have already begun accrual. Now, this morning, we heard the results of the Emerald trial that compared elacestrant, presented by Aditya Bardia in the general session. Now, just a quick reminder, the Emerald trial enrolled patients who had no more than 2 lines of endocrine therapy and no more than 1 line of chemotherapy, and they were randomized to receiving elacestrant versus physician choice endocrine therapy for co-primary endpoints of progression-free survival in all patients and progression-free survival in mutant ESR1. And these are the primary endpoint results, the Kaplan-Meier curves. On your left is the data for all patients, the intent to treat, where elacestrant was associated with a 30% reduction in the risk of progression or death in all patients with ER-positive, HER2-negative breast cancer. The median progression-free survival improved from 1.9 to 2.8. The hazard ratio was 0.69, which was significant. On your right are the data for patients whose tumor harbor mutant ESR1. And here, elacestrant was associated with a 45% reduction in the risk of progression or death, and the progression-free survival doubled from 1.9 months to 3.8 months. Similar results were seen when elacestrant was compared to fulvestrant. About 70% of this patient population had been treated with fulvestrant in the control arm, and even there you saw similar results in intent to treat and in the mutant ESR1 population. But what was really interesting was actually the result of the PFS rates at 6 to 12 months. As you can see, there's an early drop-off that you see in both arms in the first 2 months, which is perhaps related to the endocrine resistance, primary and secondary. But once you have the endocrine-sensitive patient population, you see the separation of the curves. But more importantly, the PFS rates at both 6 months and 12 months was higher in the elacestrant arm compared to the standard of endocrine therapy arm. So what about the side effects with these agents? Now, we do not see the regular deep vein thrombosis or endometrial cancers that we've seen with tamoxifen. But what we see here most commonly is gastrointestinal side effects, namely nausea and diarrhea. For example, in the EMERALD trial, the most important treatment-related emergent adverse event was nausea, which was predominantly grade 1 or 2. We also see fatigue, which we see with many anti-cancer therapies. We see some arthralgia and hot flashes. And we also see some unique side effects such as bradycardia and visual disturbances with some of these compounds, the pathophysiology of which is really unknown. So what is the key takeaway from oral SERDs? I think oral SERDs are active in the metastatic setting, and they're generally safe and well tolerable with some unique side effects that we still have to yet understand, but they are grade 1. They are effective post-CDK4/6 inhibitors and in mutant ESR1 population. We know that there is a clinical unmet need post-CDK4/6 inhibitor therapy. The current progression-free survival with single-agent fulvestrant in this setting is approximately 2 months based on the Veronica trial that has been reported out. And from the EMERALD trial presented by Dr. Bardia, we saw a statistically significant but a modest increment in PFS compared to the current approved endocrine therapy in second or third line metastatic setting. The PFS was higher in the mutant ESR1 patient population, and the PFS rates were higher at the 6 and 12-month time point, which was reassuring. Data for other SERDs in the same setting are awaited, and it is possible that this might be a new standard of care for this subgroup of patients who might be appropriate for treatment with single-agent endocrine therapy post-CDK4/6 inhibitor therapy. But like what we do in clinic today, where we try and even use combination strategies, we do require combination strategies to further improve outcomes with these agents as well, post-CDK4/6. There are some unanswered questions in the metastatic setting. One being, can we delay the emergence of ESR1 mutation? Does the endocrine therapy really matter in combination with CDK4/6 inhibitors when utilized in the first-line metastatic setting? We have phase 3 trials already ongoing with oral SERDs with CDK4/6, comparing them to AI with CDK4/6. And I'd call your attention to the PARA trial, which is going to be presented by Francois Bedard tomorrow at the session. But there was a press release that came out yesterday, which suggested that there was a switch when you have patients who switch with first-line AI palbociclib to fulvestrant plus palbociclib due to ESR1 emergence, there was a doubling of PFS from 5.7 to 11.9 months. So we look forward to these data tomorrow. And similar strategy is already being utilized with oral SERDs from AstraZeneca, the SERENA-6 trial that is currently enrolling. Now, will these agents become a partner of choice for PI3K/AKT/mTOR inhibitors, especially if there is also a mutant ESR1 mutation? I think trials will suggest that, and looks like that would be the wave of the future. And we need to understand the mechanisms of resistance for these agents as well, the way we understand a little bit about for tamoxifen, AI, and fulvestrant. What about unanswered questions in the early stage setting? Would these agents be superior to all approved endocrine therapy in all-comer patients? At least early data by Sarah Hurwitz, as we discussed from the Cooperative Trial, did suggest that the Ki67 suppression was higher with oral SERD compared to AI. It is possible that there might be better adherence, possibly with some of these agents in the early stage setting. One advantage that we have with these agents is that dose reduction for a patient who cannot tolerate a given drug at a current approved dose is possible with these agents, given the data that we have from metastatic trials. But we cannot do that with AI and tamoxifen in early stage patients. What about for our high-risk patients? Should we be thinking about escalation strategies in combination with abemaciclib, or will single-agent oral SERD be enough in this setting? What about optimal timing for our designs in early stage setting? Should we be thinking about upfront strategy where we just compare a SERD upfront to a AI or tamoxifen? Should we be considering switch strategies where patients first get AI or tamoxifen for 2 years and then are switched over to get an oral SERD? Or should we be thinking about delaying late distant recurrence and utilizing them as extended endocrine therapy? A lot of questions that we need to address, and hopefully data from planned and ongoing trials will address these. Let's move on to novel next-generation serum estrogen receptor modulators, or SERMs. Lasofoxafene is a next-generation non-steroidal SERM that was originally developed to treat vulvovaginal atrophy and osteoporosis. In fact, we got a lot of safety data from a very large phase 3 PEARL trial that evaluated over 8,600 patients to establish the safety. And this drug already has an FDA Fast Track designation. It binds to ER with a similar potency and similar fashion to estradiol and causes a conformational change that prevents recruitment of cofactors. It is effective in inhibiting metastases to the lung and liver in ESR1 mutant models, and 2 trials have already completed accrual. The phase 2 ELAINE trial, which compared lasofoxafene head-to-head with fulvestrant in ESR1 mutant patients, and then we also have the combination of lasofoxafene with abemaciclib in the ELAINE-2 trial, and we're hoping to hear the results from these studies, hopefully at ASCO next year. Moving on to basaldoxaphene, which is a third-generation non-steroidal SERM. And really, it's a mixed SERM-SERD hybrid that is already approved in Europe for osteoporosis. It has shown activity in tamoxifen-resistant xenograft models and also showed improved potency against ESR1 mutant when compared to tamoxifen. It is currently being evaluated in combination with palbociclib in ER-positive, HER2-negative metastatic breast cancer. What about Circa, serum estrogen receptor covalent antagonist? These target a unique cysteine, C530, in wild type and mutant ER that are not conserved in other nuclear hormone receptors. Now, H3B6545 is the first-in-class Circa developed by H3 Biomedicine, a subsidiary of ESI, that binds with ER irreversibly and enforces a novel antagonist conformation without degrading the ER. It appears to have increased efficacy in combination with palbociclib. It is already evaluated in a phase 1 trial. Here are the patient demographics from that trial. Of the 94 patients, these patients had received a median of 3 prior lines of therapies. About a third of these patients had 4 or more lines of therapies, including 85% with prior CDK4/6 inhibitor. About 70% had prior fulvestrant, and 50% had prior chemotherapy. About a third of these patients had ESR1 mutations detected at baseline. And in this treatment with H3B6545 at 450 milligram dose led to an overall response rate of 17% and clinical benefit rate of 40%. The median PFS in all patients was about 5.1 months, and in the 10 patients with clonal Y537S mutations, median PFS was 7.3 months. With respect to safety, grade 2 or higher adverse events of anemia, GI side effects, elevated LFTs, and bradycardia and QTc prolongation have been reported with this trial. In fact, a combination of H3B6545 plus palbociclib was presented as a poster earlier today in about 22 patients where they established the safety with 2 dose cohorts at lower doses of H3B6545 at 300 milligrams and established this similar safety profile with higher neutropenia rates as expected. And there is also activity seen despite prior CDK4/6 inhibitor therapy. So what is the key takeaway from novel SERMs in Circa? That lasofoxaphene, basaldoxaphene, and H3B6545, they modulate the ER. They do not necessarily degrade the ER. There is activity either expected or seen in both ESR1 wild-type and mutant patients. There's advantage for novel SERMs or SERDs with respect to their safety profile. It's already established to have a better safety profile with respect to sexual side effects or bone health. And we still need more efficacy and safety data from larger trials. We just have early data from phase 1 studies at this point. Now, what about complete estrogen receptor antagonist or CERAN? We know that tamoxifen is not a complete antagonist. And preclinical data has suggested that ER degradation alone might not be enough to necessarily inhibit ER signaling, and that we might need full antagonism. And OP1250 is a complete estrogen receptor antagonist, which is first in class. And data from a ongoing phase 1 trial, the phase 1A dose escalation portion, was presented as a poster again today by Erica Hamilton. And of these 40 patients that were treated with this molecule, 50% had ESR1 mutations at baseline. About 50% had more than 3 lines of endocrine therapy. About 70% had prior fulvestrant, and 73% had prior chemotherapy. 90% had prior CDK4/6 inhibitor therapy. And in the dose cohorts that were anticipated to be the recommended phase 2 dose of 60 to 120 milligrams, the overall response rate reported was 18% and clinical benefit rate of 38%, activity seen including in ESR1 mutant patients. With respect to safety, however, the safety profile included grade 1 to nausea, fatigue, grade 1 for topsy or flashing lights, grade 1 asymptomatic bradycardia, and grade 3 for neutropenia. Last but not the least, we'll review proteolysis targeting chimera or PROTAC. Now, PROTAC have ligands for one, the hormone receptor itself, so in this case, the estrogen receptor, and they have another ligand for E3 ubiquitin ligase. And so when PROTAC binds to the hormone receptor, it then recruits the E3 ubiquitin ligase complex, and this leads to polyubiquitination of the ER, leading to degradation via the proteasome. Now, what is nice here is that these PROTACs can cause complete inhibition of this ER and full antagonism of this ER, and it does not cause any conformational changes of this ER, does not modulate it. Only a small amount of PROTAC or a weak amount of PROTAC is required to bind with the hormone receptor, and that itself is enough to tag it for degradation. And so these PROTACs can undergo multiple rounds of activity, and therefore they can remove even small substoichiometric quantities of proteins. Aromatase had this first-in-class molecule, ARV-471, and a phase 1 trial. In a phase 1 trial, the patient characteristics are shown here on this slide, where all patients had received prior CDK4/6 inhibitor therapy, 70% had prior fulvestrant therapy, 38% had chemo. And interestingly, about a quarter of these patients had also progressed on prior investigational oral SERD therapy, for a median prior lines of 5 therapies. And despite this heavily pretreated patient population, including prior CDK4/6 and investigational Certs, the clinical benefit rate here was 42% in this trial. It was rather well tolerated, with most common toxicities being grade 1 to nausea, arthralgia, fatigue, and some decreased appetite. We will hear updated results from this study on Friday. Erica Hamilton will present the updated results at a poster on Friday, so watch out for that data. So key takeaway from CERAN and PROTACs is that OP1250 and ARV-471 do not modulate the ER. They are ER antagonists, and in fact, ARV-471 can also degrade the ER. They both have shown activity post-fulvestrant, post-CDK4/6, and in fact, one might think that perhaps PROTAC might also be active post-oral SERDs. However, the activity and the safety profile that we've seen to date with both these agents needs to be confirmed in larger trials, and we also need to understand what kind of mechanisms of resistance these agents might have. So in conclusions, the ultimate selection of all these novel endocrine agents that are currently in development will be dependent on their optimal therapeutic index and their efficacy. What we've seen from these phase 1 trials is that they're effective after fulvestrant and CDK4/6 inhibitor therapy, and in patients whose tumors harbor mutant ESR1 mutation. Oral SERDs are the furthest in development and may have the potential to replace current approved endocrine therapy in the second or third line setting post-CDK4/6 inhibitor therapy. At least based on the EMERALD trial, it was apparent that progression-free survival is higher in those patients whose tumor harbor mutant ESR1, and PFS rates were higher at the 6 and the 12-month time point. We do await data from the other SERDs in this space and also for combinations with PI3K/AKT/mTOR inhibitors in the second-line setting. They are rapidly being evaluated in the first-line setting in combination with CDK4/6 and also being evaluated in early-stage setting. But the activity of the other novel agents and the safety have to be confirmed in larger trials. And I'll leave you with this big picture question that we want to think about is that how do we figure out a way to optimally sequence these agents to further improve outcomes for our patients? And how will cost really impact their utility for our patients as well, both in late stage and early stage settings? And one thing that we have learned from these agents is that while they can address one mechanism of endocrine resistance, which is ESR1 mutation, we do require other agents and potentially other combinations to tackle the ligand binding domain mutation independent mechanisms of endocrine resistance. With that, I'd really like to thank all my friends and colleagues, to our patients and their families who really inspire us in doing what we do every day. And thank you all for your attention.